Hello, everyone, and welcome to our webinar. PAHCOM is very proud to have a partnership with CMS to offer e-health education and training specific to small practice management. That's what we do here, and we're really happy to have all of you joining us today. Just a few notes. The question and answer is on the left part of your screen. You see the chat window there. Please go ahead and send your questions whenever you have them, and the speaker will address those questions either at a natural break or at the end of the webinar. We will have time set aside for questions at that time. Also, this webinar is being recorded. The video webinar will be available on the PAHCOM YouTube channel. Usually give us about, it should be up there today, but maybe 24 hours at the most. And you can go there and you can see not only this webinar recording, but previous webinar recordings that we've done through the CMS partnership, also specific to small practice. All of our webinars are specific to small practice, so please be sure to check that out. It's also really, really great to use the recordings to go over specific points of the webinar with your staff and or physicians. And yes, one CEU is being approved by PAHCOM for this. We approve CEUs for live educational webinars, and if you're a PAHCOM member, you can just go to your CEU log and add it there. Otherwise, you're certainly welcome to request a certificate at ceu@pahcom.com, and if you need a certificate and you are a member, you can also request the certificate. It is my honor and privilege to introduce today's speaker. Rob Anthony is the lead for Policy and Outreach and Deputy Director of the Health IT Initiatives Group in the Office of eHealth Standards and Services at the Centers for Medicare and Medicaid Services, CMS. Mr. Anthony oversees policy development, implementation, and outreach efforts related to CMS eHealth initiatives and the Medicare and Medicaid Electronic Health Record Incentive Programs. Thank you very much, and welcome, Rob Anthony.
Thanks, Karen, and thanks to all of you for attending this afternoon, and thanks especially to PAHCOM for hosting this webinar. I'm going to talk a little bit about Stage 2 and 2014 clinical quality measurement. We're going to talk a little bit about what's changing in 2014. I want to talk some about payment adjustments and a little bit about audits, because those are questions we're getting a lot about. But before we go into any of that, I want to talk a little bit. There was an announcement that came from CMS on Friday, and it concerned a movement of the Stage 3 timeline, and I think it's caused a little bit of confusion. So before we go anywhere, I want to try and clarify that for folks. Some of you may have heard we made an announcement Friday afternoon that we are extending the Stage 2 timeline, which effectively means that Stage 3 will not begin until 2017. The way that it is currently sketched out in regulation is that Stage 3 was supposed to begin in 2016 at the earliest for people, but we are moving that a year out to 2017. And we're doing that for a few different reasons. One is because of where we are on the calendar now. It would not be enough time for us to go through the entire rulemaking process, where we actually publish a notice of proposed rulemaking and we accept public comments and we consider stakeholder advice, and then we come up with a final rule, and then allow EHR developers to actually develop new software to meet those requirements in time for everybody to start Stage 3 in 2016. So we've moved that Stage 3 timeline out to 2017. That is only a movement of the Stage 3 timeline. We have been getting the question about whether that represents a delay for Stage 2. It does not. Nothing about the Stage 2 timeline and when Stage 2 potentially starts is changing at all. It is still set to begin in 2014. 2014 will still be the special reporting period. That's a 3-month reporting period under Medicare, 90-day reporting period under Medicaid. And nothing is changing there, and there is not a Stage 2 delay. So I just want to clarify that as we are going to talk about Stage 2, that there is not a Stage 2 delay. What we have effectively is a delay in Stage 3 until 2017. So with that said, let's talk a little bit about Stage 2 and what is coming next year. So what we have with Stage 2 is some new criteria, some things that in 2014 for providers who have already done at least 2 years with Stage 1. Moving to Stage 2, we'll have some new objectives, and we'll talk about what those new objectives are. We have some things that are focused specifically on improving patient care through clinical decision support, through care coordination, through patient engagement, and again, we'll highlight those objectives and where they are. And then, of course, the real focus here in doing all of this is to get us to this point of improved outcomes. And those are improved patient outcomes and improved financial outcomes for the healthcare system. The idea of saving money, saving time, saving lives. And again, we'll go and look at those objectives and see how we do some of those different things in here. But as many of you know, I just want to do a quick refresher about meaningful use. This is a 3-stage process. We're going to talk about this middle stage, Stage 2, that we are focused on. If Stage 1 was really about data capture and sharing, if it is about recording information and getting your EHR in place, Stage 2 is about moving that data along the care continuum. It is about information exchange to the next provider of care. It is about information exchange to the patient themselves, all with the idea of improving care coordination across multiple settings. Stage 3, which has not been enumerated yet, there's no regulation out for Stage 3 yet, is going to be about improving outcomes, both from a patient outcome as well as from a financial outcome. And that really is the focus that we have. Remember that this is a step process. So even though we talk about Stage 2 beginning in 2014 and we're talking now about Stage 3 beginning in 2017, if you're a new provider, you always begin this program at Stage 1. Always. You're always going to have a first year of meaningful use is 90 days at Stage 1. And then you move on to a full year at Stage 1, and then you move on to Stage 2. So just keep that in mind. Stage 2 will begin next year for those people who either began meaningful use in 2011 or 2012. If you're a provider who this year was your first year of meaningful use, 2013, then 2014 is going to be another year at Stage 1 for you, and you won't do Stage 2 until 2015. If that's a little bit confusing, like I said, one of the things that we have, I'm going to actually flip forward in the slide and show you something. One of the things we have is a participation timeline tool that you can go and take a look at. Obviously, this timeline widget has not been changed to reflect the Friday announcement, but it will give you an idea of starting Stage 2. You can go in, you can talk about which program you are participating in, you can tell the year that you first started, and it will customize a timeline for you. So you can go to this website below, and it will show you that. A handy thing to keep in mind when you think about when you're starting Stage 2 is essentially taking your first year of meaningful use and adding 2 years to that. So if your first year of meaningful use was 2013, this year, you add 2 years to that, and you're beginning Stage 2 in 2015. If your first year of meaningful use was 2012, you add 2 years to that, well, you'll begin next year in 2014. The only people this doesn't apply to is if you began your meaningful use in 2011. Obviously, you wouldn't have begun in 2013. You're not going to begin until next year. So for those of you who are familiar with Stage 1, I want to talk a little bit about what some general changes are to the overall structure of meaningful use, and then we'll talk about specific objectives. So one of the things that does change is the way that menu objectives are working. I think if you think back to how you're doing things now in Stage 1, you can claim an exclusion to a menu objective even though you select that particular menu objective. We allowed that so that there could be maximum flexibility for providers. Moving into Stage 2 and 2014 and beyond, even in Stage 1, that's not going to be an option anymore. If you if there are menu objectives that you can report on, then you have to select those menu objectives to reach your 5 minimum or 3 minimum in stage 2. You can't select and exclude from something if you can report on something else. So essentially, we've closed a loophole. There are a lot of things that haven't changed, however, as you move into 2014. You still have to have at least 50% of your patient encounters at a location that's equipped with Certified EHR technology in order to participate. You still meet the measure of the objective, of each objective, and that's how you meet meaningful use. So, meeting meaningful use is meeting those measure thresholds of 50% or 30% or 80%. And your denominators are still going to be based on all of those outpatient locations that are equipped with Certified EHR. So if you meet that 50% threshold, then you basically aggregate the information that you have from all of the locations that have Certified EHR. And that is consistent with how things are working now and will continue to work that way in the future. One of the things that does change as you move into 2014 is that you have to upgrade your Certified EHR technology. Everybody right now has EHR technology that is certified through the end of this year. But you're going to need to upgrade next year to 2014 certified technology. And the reason you have to do that is because there are new requirements in stage 2, and there are also new requirements in stage 1 as we move forward. So EHR technology has had to be updated for those new requirements. There are also new clinical quality measures, and those are for everybody, whether they are stage 1 and stage 2. So you need Certified EHR technology that is able to measure all of those new clinical quality measures. It doesn't matter if you are in stage 1 or stage 2, you still have to upgrade to a 2014 certified edition. And there are folks, I know, a small number of folks whose vendors have certified ahead of time and they have managed to be upgraded. It is possible for you in this final portion of 2013 to be using that 2014 certified EHR technology. It doesn't affect most of you, but for those of you who have upgraded early enough, it certainly is a possibility. And you would just choose that technology from the Certified Health IT product list when you get that certification number for attestation. So this is the essential structure of stage 1 on the left. You had 15 core objectives for eligible professionals. The reason it says 14 here is because one of those objectives was testing information exchange. And that objective was actually eliminated in 2013. So if you are used to seeing 15 core objectives and you're seeing 14, that is why. And of course, there was the menu objectives, and you selected 5 out of 10 of those menu objectives. So you're reporting on a total of 19 right now. In stage 2, we maintained that core and menu structure. So there are core objectives on which everybody has to report or claim an exclusion, and there are 17 of those. There are also menu objectives, and you select 3 out of 6 of those menu objectives to attest on. So a total of 20 total objectives that you would be presenting on or attesting on. Many of those objectives are things that you have already seen. They are things like submitting information. You can see some of the updated requirements at the bottom. They are things like submitting information to an immunization registry and patient reminders. Some of them are brand new objectives, such as secure messaging, recording a family health history, incorporating imaging results into your EHR, reporting to a specialty or a cancer registry, recording progress notes in your EHR. These are all new core and menu objectives for stage 2. So stage 2 is a combination of things you've already seen and some new things as well. I'm not going to go through each of these, but these are a list of the core objectives. You see some of them. Most of them here are familiar. Computerized provider order entry, which was something that was being done for medications in stage 1. Now will be done for medications, lab orders, and radiology orders in stage 2. E-prescribing was something from stage 1 that is also in stage 2, and what we've done is we've raised the threshold that you have to hit for that. recording demographics, recording vital signs, so on and so forth. You will notice that there are some core objectives from stage 1 that are no longer being measured individually. Things like recording a problem list, recording a medication list, recording a medication allergy list. We are no longer measuring those individually. However, you still have to record problem list, med list, and med allergy list as a part of other objectives. So if we look at the next page with core objectives, you'll see core objective number 10, which is providing online access, patient access to health information, and core objective number 15, which is providing a summary of care document with transitions of care and referrals to the next provider of care. Both of those objectives require sending a problem list, a med list, and med allergy list as part of it, which means you as a provider would have to continue recording those elements. We're just not measuring them as separate objectives. These are the menu objectives for stage 2, and I've chosen to focus here on eligible professionals because I think that's what most of you are working in a practice with eligible professionals, physicians, some of you on the Medicaid side with nurse practitioners. There are a separate list with a lot of overlap for eligible hospitals, so if you come from that type of a background, please visit our website. There is some information there on stage 2 core and menu objectives for eligible hospitals, but I'm just covering eligible professionals here. But these are the list of menu objectives. There is not a specific requirement for how these work. You can pick any 3 out of the 6 here. I want to focus in on a handful of objectives that are really the focus of stage 2. So when we look at stage 2, and you see a lot of objectives that you're already familiar with, and you see a lot of objectives that are new, there are obviously some objectives that we place more importance on than others because we believe that they will have the most effect on patient care. So one of the focuses in stage 2 is patient engagement. And you will see that there is a requirement in a couple of different areas for patients to actually take a specific action in order for an eligible professional to meet meaningful use. And that's a change from stage 1, because in stage 1, there was really nothing that a patient could or couldn't do that would affect whether an EP could reach meaningful use. Even if an example that we often get is the office visit summary, an aftercare summary. Even if a patient decides that they don't want that office visit summary, a provider simply has to offer it to the patient, and they can include that patient in the numerator. So the patient declining that wouldn't have an effect on whether that EP meets meaningful use. But in stage 2, we have introduced some very low thresholds for patient participation as a component of meaningful use. One of those is in secure messaging. There's an objective for utilizing the secure messaging function that is built into 2014 Certified EHR Technology for the patient to actually send a secure message to the EP. And the requirement is a low threshold, but more than 5% of patients sending a secure message to the EP. Similarly, there is a requirement to provide patient access online to health information. One of the measures of that objective is that information is provided for 50% of all the patients that are seen during the reporting period, and that is a requirement for the EP. But the other requirement is that patients are actually accessing that information online, and so we have this second measure of more than 5% of patients actually accessing that health information through that online portal. So again, the idea here is to try and drive some patient engagement. There is an exclusion for both of these based on broadband availability in the provider's county, and you can read a little bit more about that on our website. We've also tried to focus on actual use cases of electronic information exchange. And I'm sorry, the header on this slide is a little bit misleading because this is more about information exchange than it is patient engagement, because information exchange is a big component of interoperability and meaningful use for stage 2. So In stage one, we had a menu objective item that you would send a summary of care to the next provider of care in any transition of care or referral. And there was a minimum threshold that you had to meet for that. That menu objective from stage one has become a core objective that everyone has to meet in stage two, and we've expanded it with an electronic component so that we can encourage actual information exchange through electronic means. So there is this requirement that a provider, you'll see three different requirements here to meet this objective. And the first requirement is that a provider sends a summary of care record for more than 50% of transitions of care and referrals. And that's essentially however that happens. It can be a mailed copy of a paper summary of care. It could be an emailed copy. It could be faxed. It could be, you could send it by carrier pigeon if you have a reasonable expectation that the pigeon knows where to get. But there's also an electronic component, and that's where you see the second measure, that more than 10% of the transitions of care and referrals, the provider has to actually electronically submit that summary of care in a particular standard, which in this case is utilizing the CCDA. It's a consolidated care document architecture. And all EHRs that are certified for this program have that CCD built in. And you also have to send it either by a health information exchange or by using the direct protocol. It's a transportation standard, and if you don't understand what direct is, that's okay. You can take a look at some information on our website, but most EHRs are going to utilize some version of direct in order to make that possible. And then finally, there's a third measure to this objective, and that is that at least one of those summary of care documents that you send during the entire period has to be sent to somebody who has a completely different EHR vendor than you do. And the idea here is to really encourage information exchange outside of organizational walls, outside of vendor and technology walls, because we want to make sure that information can flow freely from care setting to care setting, regardless of what EHR a provider is using. And again, it'll utilize that CCDA format that I discussed. It'll utilize one of the electronic transmission methods that I discussed, but it just has to be to somebody with a different EHR vendor. If you're in an area where that doesn't happen just normally, and we do think that most people are going to be able to do that third measure simply by sending in their normal course of clinical workflow to the next provider of care. But if you're in an area that has a high saturation of a particular EHR vendor, or you have an organization that doesn't facilitate this very easily, there is a CMS designated test EHR that you could use to send things to. We're going to have information shortly on our website about how to actually do that and what that'll be. So beginning in 2014, regardless of whether you're in stage one or stage two, there's going to be a change in how clinical quality measure information is reported. And I'm going to go through this quickly, but we do have a guide, and we'll have a beginning guide on our website relatively soon about this. But I just want to emphasize that the CQM requirements are regardless of your stage of meaningful use. It doesn't matter whether it's stage one or stage two. It is tied to the year that you are in, or I'm sorry, it is tied to the year of 2014 as the changeover. It is tied to what comes out of your EHR. So again, this hasn't changed from what you're doing now. You're going to report the output of those clinical quality measurement from your certified EHR. What has changed, I'm sorry, I'm going to skip over this slide in the interest of time. There's a little bit of a timeline issue here. What has changed is the way that quality measures are structured for reporting. You can see up top here right now, this year, this is how we are breaking down clinical quality measures. We have the 3 required core measures or alternate core measures. Then there's a total list of 38 additional measures, and you choose 3 out of those. We're moving to a total of 9 measures in 2014 that you'll report on. And we are looking at a domain concept that I'm going to talk about in a second. But there are going to be a couple of different ways that you can report. One of them is what you see here in option 1, and that is reporting 9 measures. out of a total of 64 that we have available across different domains or buckets of different clinical quality measures. The other thing that you can do is you can report measures if you're an EP under PQRS, which is the Physician Quality Reporting System. It's an electronic reporting option. And if you report that way, you will get credit not only for reporting to PQRS, but also to the EHR incentive program. And then finally, we have some group reporting options. There are group reporting options under PQRS. If you're an EP who is taking part in a accountable care organization, reporting quality measures through the accountable care organization will allow you to qualify for reporting CQMs under EHRs as well. So at base, what really comes down to is that you're using the new 2014 Certified EHR. You're reporting the data for those CQMs directly from that Certified EHR. And you're, for attestation and the aggregate electronic reporting methods, whether you're going through the PQRS electronic reporting method or whether you are reporting directly through the CMS website for attestation, you're reporting on the CQMs that are actually certified within your EHR. Very quickly, if you are using a 2014 edition EHR right now in 2013, you do have to report on CQMs that are included in that are included in both Stage 1 and Stage 2 final rules. We do have some more information available on our website, and we'll talk about that. I'm sorry, you can visit our website and get some more information about doing that. I think that probably doesn't affect the vast majority of folks, so I don't want to dwell on that too much. So again, option one is reporting through Certified EHR Technology. You're looking to report 9 clinical quality measures out of 64 across these different domains, and I'm going to bring up those domains in a second. We do have a suggested core set of clinical quality measures if you're looking for some guidance there. There's a core set for adults, there's a core set of children, and they represent sort of the high priority clinical conditions that we're looking for quality measure on. You would submit this on an aggregate basis. This would go through attestation. It would be regardless of who is the payer, so you are submitting aggregate information across everybody during a reporting period. It doesn't matter if they're a Medicare or Medicaid patient or a third-party private patient. We're going to collect aggregate information on everything. So again, not patient-specific, but aggregate. The other option here, which if you have the latest, most updated certification specs for your EHR, you can report electronically through the Physician Quality Reporting System option. Your EHR will be certified to actually compile and submit that data. There obviously is a different reporting period for PQRS. So we'll have, again, some information on our website about how that will happen, but essentially it will happen after the close of the calendar year, and it will happen separately from your actual meaningful use attestation. And then finally, as I said, there's some different group reporting options. If you're participating in an ACO and you submit you submit clinical quality measures through your ACO attestation, that will essentially deem you for having met the clinical quality measure reporting for EHR. Similarly, if you're an EP who is participating in PQRS as part of a group, it's called the PQRS G-Pro option, then you can satisfy the requirements that way as well. A lot of folks are submitting some information or some questions on the side in chat about CQM reporting, and I'm going to briefly stop and say that answer a couple of these questions because it probably helps to do this in context. So the question about whether reporting a CQM would it occur during attestation or not is dependent upon which method you actually use. If you use the attestation method and you only want credit for submitting to EHR incentive program, you can submit information at the time of attestation. If you are submitting information and you want credit for both the EHR incentive program and PQRS, then you have to submit electronically through PQRS for that, and it would happen separately from attestation. Similarly, if you're participating in an ACO and you want credit for both ACO and EHR incentive program, you're going to submit those quality measures through the ACO attestation, and that would be separate from the EHR attestation. CQM reporting does remain just a reporting requirement, so it's going to be numerator denominator through attestation. There's some more patient sampling, obviously, that happens with PQRS for those of you who are familiar with it, but there isn't a threshold to hit for any of those clinical measures. It is simply a matter of reporting what information is in your EHR. And then somebody asked about EPs submitting their CQMs in 2014. That appeared to be a new option, and it is an option for folks. We previously had indicated that everybody would have to submit electronically through a couple of different methods. We did release a regulation recently in which we changed what those options are. So essentially your options are going to be submitting through attestation, submitting electronically through PQRS, or submitting through one of the group options, either as an ACO or through PQRS. So these are the 2014 clinical quality measure domains. There are a total of 64 clinical quality measures from which you can choose to report on if you are an eligible professional beginning in 2014. And all of those 64 fall into one of these 6 clinical quality measure domains. If you are familiar with how we've developed meaningful use objectives, or you're familiar with any of the other quality improvement programs that the Department of Health and Human Services uses, you'll recognize these domain names. These domain areas represent sort of the quality improvement strategy areas for the Department of Health and Human Services. So one of the requirements that we've put around clinical quality measure reporting beginning in 2014 is that clinical quality measures from at least 3 of these different domains are represented as part of the 9 you select. If you select the 9 recommended set of clinical quality measures, whether the one for adults or the one for pediatrics for children, those clinical quality measure domains are represented within those. But if you choose to select any 9 from a total of 64, then you just want to make sure that you have these different domains represented. It will be easier than you think when you go and do this in attestation, because in attestation these are actually broken down by domain, and the system won't let you proceed forward unless you have at least 3 of the domains represented. But you can also go onto our website and you can look at the clinical quality measures and the domains they fall into right now if you want to start planning for that. So just very briefly, I want to run through some high-level changes of what is changed for 2014 EHR certification. On the left, you can see sort of the visual conception of what Certified EHR looks like right now. It's basically, this is certification. You get a complete EHR, which means that you have to have access to an EHR that is able to do everything that is required from both core and menu objectives, regardless of whether you're actually going to meet certain objectives. And many of you know that there are exclusions to the objectives that you can qualify for. So, for example, you might qualify for an exclusion of e-prescribing because you write fewer than 100 prescriptions during the reporting period, which is why we've moved to the bullseye target-looking thing on the right, a more dynamic definition of certification, which is actually driven by what you are going to do, what you're going to demonstrate in meaningful use. And essentially what this means is that we are moving away from this idea of a complete EHR, and we're moving to this idea of an EHR that contains the modules that you need to meet meaningful use. So While we will continue to certify complete EHRs, and while we will continue to certify individual components of EHRs in a modular way, so for example, an e-prescribing module could be certified separately from an entire EHR. For you as a provider, it basically means that you don't have to get every capability. You don't have to get a complete EHR. If you are a provider who does not e-prescribe, you do not have to get hold of an e-prescribing module for your EHR, spend that extra money. You just need the basic EHR modules that are necessary for you to meet meaningful use. And there's some more information to get on our website if you want a more in-depth discussion of that. There are a lot of slides under payment adjustments and hardship exceptions. They're here primarily for your information, but I'm going to try and make payment adjustments a very simple concept for everybody. So payment adjustments begin in 2015 for people who have not demonstrated meaningful use. We are looking at a previous period to see if you have demonstrated meaningful use before we apply those payment adjustments. So if you're an EP, payment adjustments would begin January 1st of 2015. We're going to look to see if you had a meaningful use period prior to that, and if you did, then you won't get assessed a payment adjustment. If you were a meaningful EHR user in 2011 or 2012, then we're basically going to look at 2013 to see if you demonstrated meaningful use. And if you did, then you won't be assessed a payment adjustment. And you just attest normally the way that you normally do. For most people, that'll mean a full year attestation in 2013. You would attest by the end of February in 2014. If you've never been a meaningful user before, meaning that you will be a meaningful user this year in 2013 or a meaningful user in 2014, then you need to attest by no later than October 1st of 2014, which means that you need to have an EHR reporting period by September 30th of 2014. And essentially this gives us a 3-month grace period in which to process your attestation and make sure that you are not assessed any payment adjustment beginning in 2015. If you are applying for a hardship exception, and I'll talk a little bit about how to do that and what those categories are, you as an EP must apply by July 1st of 2014. That process is not open yet. It will be open next month, and we will have more information on our website about how to submit a hardship exception for the payment adjustments, but that is when you would submit by. So payment adjustments are, again, they are apply if you are not a meaningful user. If you demonstrate meaningful use under either Medicare or Medicaid, it is okay. We just need you to demonstrate meaningful use under one of those programs. But it has to be a demonstration of meaningful use. If you are receiving an adopt, implement, upgrade payment through Medicaid, but you also have Medicare patients, that's not meaningful use, and you're going to end up with a payment adjustment against your Medicare claims. The rest of these slides, I think, get a little bit more complex, but essentially the important thing to understand is that what you're facing as a payment adjustment is a reduction in your Part B physician fee schedule payments. Those are essentially amounts to a 1% adjustment in 2015, and then it escalates from there. It is not tied to you not being a meaningful user after a certain period of time. It is tied to a specific year. So if you were a meaningful user and avoided the payment adjustment in 2015, but the following year you were not a meaningful user, then you would be assessed a 2% penalty in 2016. So it isn't cumulative. It is actually tied to a particular year. And essentially what these following slides demonstrate is the slide that I had showed earlier that tells you when you have to attest and be a meaningful user by. This breaks down by year, what reporting period we will look at in what year for you to avoid penalties in specific payment years. Do keep in mind that to avoid those payment adjustments, you have to continue demonstrating meaningful use every year. So it's not a one-and-done deal. You have to be a meaningful user year after year to avoid payment adjustments. And I won't go through all of these. There is a payment adjustment tip sheet on our website for eligible professionals that will describe this in a little bit more detail, but we basically covered that in the earlier slide. And so again, if you're eligible for both programs, you could participate in either Medicare or Medicaid. You just have to demonstrate meaningful use under one of those. So let's talk very briefly about hardship exceptions. So if you are an EP who is in a specialty like anesthesiology, radiology, or pathology, if you're one of those three specialties, you don't have to apply for a hardship exception. You will be automatically granted a hardship exception as long as those specialty codes are indicated. And basically this is because you fall under a hardship category of lacking face-to-face or telemedicine interaction with patients, you lack follow-up need with patients. If you're an anesthesiologist, radiologist, or pathologist, you have such limited interaction face-to-face with patients that it's difficult for you to meet meaningful use. Everybody else has to actually apply for a hardship exception. Whether you're an EP or a hospital, you would apply. That the hardship exception only applies to avoiding payment adjustments. It does not apply to anything having to do with receiving an incentive payment. It is only to do with payment adjustments. We are only going to grant hardship exceptions if you have demonstrated the circumstances that pose the barrier to achieving meaningful use, and you will see that the hardship exception sheet that you would fill out, the application that you would fill out, will tell you exactly the documentation that we were looking for you to prove that. Again, if you're applying for this, then as an EP, you want to apply no later than July 1st of 2014 to avoid that payment adjustment. We anticipate there are a fair number of people who apply, so I do encourage you to apply early. And somehow we have missed the categories. I apologize for what the hardship exceptions are, but I can run quickly through those for you. And again, there is some information on our website about this. But the different categories in which you can apply are a barrier or a lack of infrastructure for internet access. There are a lot of people who are in areas, especially rural areas, that don't have broadband access. There are some EPs, again, especially in rural areas, who might be able to arrange internet access, but it's at an incredibly high premium. We've heard some very stiff figures for running a T1 line, for example, or a T5 line to getting broadband access for providers. So you could apply under that. You can apply for a time-limited exception. So essentially, if you are a new provider, you don't want to get penalized right off the bat. You could apply for a 2-year exception to the payment adjustments that allows you time to become a meaningful user and demonstrate meaningful use. You can apply. We talked earlier about this applying to anesthesiologists, pathologists, and radiologists, but it could apply to a lot of different people. If you don't do face-to-face or telemedicine encounters, and you don't do follow-up care with patients, then you could apply for an exception under that, because that is a high barrier to actually collecting information and transmitting information. You could apply for a hardship exception if you do not have any type of influence over the adoption of electronic health records in your practice. Obviously, if you are a partner in a practice, that's not an option for you because you are one of the people who gets to decide that. But there are some folks who are part-time or employees at a particular practice, and they don't have any type of say in the decision about implementing electronic health records, and that could be a barrier for them to achieving meaningful use. There will be an exception for folks who are not able to adopt a 2014 Certified EHR in time to meet the Stage 2 requirements. Some of that will be because a vendor does not have a product ready in time. Some of that will be because you might be changing over to a brand new product and you weren't able to get that product implemented into your practice in time. For some people, it will be because the product is available, but there wasn't enough time to implement it into workflow. So there's a hardship exception for that. That hardship exception will, again, only exempt you from payment adjustments. It will not do anything for you receiving an incentive payment. And then finally, there's a hardship exception category for people who, we call it our act of God category, but it is basically unforeseen circumstances. We think about people who were involved, whose practices were hit by a Hurricane Sandy. Maybe you had a vendor who went out of business and you had a cloud EHR and all of your data went with it. Whatever the case may be, there's a category for those unforeseen circumstances as well. And just really quickly, I want to talk about audits because we do get a lot of question about audits. It is true that any provider that receives an EHR incentive payment for either Medicare or Medicaid can be subject to an audit. CMS uses Figliozzi & Company as its contractor. They do audits on Medicare EPs and also on Medicare and Medicaid hospitals. States will perform individual audits on Medicaid incentive payments. We do both post-payment and prepayment audits. So you may have a prepayment audit that we ask for additional information before we actually issue your payment. We also have post-payment audits, so somebody could come around as much as a year afterwards, maybe even longer, and ask for some documentation about an incentive payment that has already been issued. You basically will be asked to submit supporting documentation that will validate the attestation data that you submitted to us. About 5 to 10% of providers are subject to an audit. That's pretty much in line with most audit programs here at CMS. We do both random audits, so randomly selected folks, as well as people who we consider to be high risk. So we do have an audit risk profile, and I can't really discuss what that is for obvious reasons, but it does highlight suspicious or anomalous data and may trigger an audit. It is possible that if you exhibit suspicious, anomalous data patterns that you might be subject to successive audits. There are some people who have had year after year audits, and that isn't unusual if you are essentially doing the same thing again and again. If you were picked for an audit previously, that automatically puts you into a category where you are looked at for an audit again. It's part of our oversight program. So if you get one audit after another, that's part of the reason why. And obviously, we can't discuss what raises the red flags because we are trying to combat any type of fraud and abuse. I'm going to go quickly through this and just talk about what the audit process is. One of these is you're going to get an initial request letter. It will come from Figliozzi & Company. They will do an initial review process of whatever information that you send as a response to that request letter. They might come back to you and ask for additional information after that initial review. It is possible that there would be an on-site review. It doesn't happen in a large number of cases, but it is a possibility, and there might be a requirement for a demonstration of your EHR system. Figliozzi & Company has a secure portal for you to upload information, so we do recognize that there have been concerns about patient information that might be provided within some of the reports that are generated. We want to make sure that that information is secure, so Figliozzi & Company does have a secure site for you to upload documents to. If you have any questions about an audit, you do have to speak directly to the audit contractor. Nobody at CMS can help resolve an audit for you once that has begun. And that is part of our oversight of the program. There's a firewall, if you will, between CMS and the auditor to make sure that we have an objective review of providers' meaningful use data. And if for whatever reason you're found ineligible for that particular payment, the payment does get recouped. Or in the case of a prepayment audit, it would not be distributed, and you would essentially forfeit that year of payment. It doesn't preclude you from participating in the future, however. The one thing that I will say about audit is documentation is key. It's your responsibility to maintain that documentation. You want to maintain any documentation that supports your meaningful use numerator and denominator numbers, your clinical quality measure numbers, whether that documentation is electronic or paper. I always recommend that people print off their reports and keep them separately. We know that nothing ever goes wrong with computers, but just in case something might go wrong with yours, it would be great if you had a paper copy of that to back up what you had. We usually look for primary source documentation, and for most people that's going to be that report that is generated by your Certified EHR Technology. You want to make sure that you have numerator and denominators, that the numerator and denominators match the numerator and denominator information you entered into your attestation module, that somewhere on that report there's a time period that shows that it's a report for your reporting period, and that there's evidence to support that the report is for you. So whether that's a NPI, for hospitals, a CCN, your provider name, your practice name, whatever it is, make sure that that is actually there. And I won't go through these. There are some additional information here. We also have a suggested documentation guidance, but you'll see that we have suggested documentation. So for drug-drug and drug allergy interaction checks, we recommend a screenshot or several screenshots from your EHR that are dated to demonstrate that that was actually active. Again, here are some links that will take you to the sample audit letters and the supporting documentation guide to give you some more information. I would also encourage you to take a look at our Stage 2 web page. It has a lot of tip sheets about Stage 2. It has spec sheets about individual objectives. There is a clinical quality measure page that will give you a lot of information. And, of course, there is an audits page that will give you some information as well. We have a handful of minutes left. That was a lot of information to go through, but I am going to try and cover some of the questions that have come up through chat. So bear with me as we go through some of these. I'm going to try to answer some questions. Somebody did ask about menu measure number 6 in Stage 2, reporting on specific cases. It mentions that providers need to, a registration of intent to initiate ongoing submission was made by the deadline. Do I know when that deadline is? It would be prior to the end of your reporting period. So if you're submitting information to a specialty registry, you just need something that demonstrates that registration of intent prior to the end of the reporting period. We did answer some CQM questions here. Somebody did ask regarding CQMs whether payment would be held for attestation in 2014 until you've submitted all clinical quality measure data, and that's a really good question to ask. So in 2014, there is a reduced special reporting period. There's that 3-month reporting period for everybody so that everybody has a chance to change over to electronic health records. If you submit your CQM data with attestation, you would only be able to get credit for your EHR incentive program, and your payment would be issued as soon as that attestation was processed. However, if you do send information through PQRS or through another mechanism, that is a full year reporting mechanism, all of 2014, and it means that you would have to wait until you have submitted complete clinical quality measure data in order to actually receive your full incentive payment. So essentially, if you use PQRS, that incentive payment gets held until we have a complete meaningful use and clinical quality measure data. Somebody did ask about radiology, anesthesiology, and pathology, how they're demonstrating lack of face-to-face. There isn't a requirement for anesthesiologists, radiologists, and pathologists to demonstrate anything in order to receive the hardship exception. You can receive that hardship exception automatically as long as you have the appropriate PAHCOS code listed in your PAHCOS registration. There's some more information about this on our website on what those PAHCOS codes need to be, but you'll automatically be granted that hardship exception. Somebody asked whether new EPs in their first year of demonstrating meaningful use in 2014 also need to submit a hardship exception, or do they just attest by October 1st of 14? All you need to do is attest by October 1st of 2014. You don't need to do both. If you are a meaningful user by October 1st of 2014, that gives us plenty of time to process your attestation and make sure that you avoid that payment adjustment. Somebody asked how payment adjustments work, and they said, if you're not a meaningful user in 2015, you're going to get a 2% adjustment in 2016. That is correct. But then they asked, if you become a meaningful user in 2016, would you go back to getting a full payment in 2017? And that is absolutely correct. So essentially, if you miss a year of meaningful use and you are not a meaningful user, you will get assessed whatever the required year's penalty is. But as soon as you become a meaningful user, you will no longer be assessed a penalty again. So it's certainly nothing that you can't come back from. Sorry, I'm scrolling through this. Somebody asked about the Stage 2 extension. Okay, so let me clarify again. Sorry, this was rather a long question. Stage 2 begins in 2014. It is not moving. Nothing that we announced on Friday has anything to do with Stage 2. What it is a movement of the timeline for Stage 3. Previously, Stage 3 was supposed to begin in 2016. Now it will begin in 2017. But Stage 2 does not move. You continue to report as normal in 2014 if that's your start year. There is no delay. There is not another year at Stage 1. It is Stage 2 as normal in 2014. There are questions about encounters at other outpatient facilities, such as nursing homes and hospitals. And somebody asked what they do with those things that fall outside inpatient and emergency room. So essentially, if you're an EP, any encounter that you have outside of POS 21, which is the inpatient department of a hospital, and emergency room, which is POS 23, place of service 23, those get counted towards your encounters. So essentially, anything outside of those, you have to have access to a certified EHR technology at 50%, at locations that represent 50% of your patient encounters. So let's take an example where you see patients in 3 different locations. Location A, which is your personal office, location B, which is an outpatient clinic, and location C, which is a nursing home. Let's say there is not an EHR in location C, and you see 40% of your patients in location C. But locations A and B both have an EHR, and you see a total of 60% of your patients in those 2 locations. You've essentially hit the 50% threshold of locations equipped with certified EHR, which means that you can limit your meaningful use calculation to just locations A and B, where there is a certified EHR, and you can essentially ignore location C, which is the nursing home. It is entirely possible, though, that you may be in a situation where you see patients at a variety of facilities, nursing homes, hospitals, a dialysis unit, a skilled nursing facility, and with all of those, they represent more than 50% of your patient encounters. and they do not have a certified EHR, in which case you would not be able to demonstrate meaningful use successfully. You have to hit that 50% threshold. So somebody asked about they're a new clinic, they just got contracted with Medicare in July. Do they need to do anything for 2013? So 2013, probably not, since we're almost done with it. But in 2014, you're going to want to acquire a certified EHR, and you're going to want to demonstrate your first 90 days of meaningful use. Otherwise, you could be assessed that payment adjustment in 2015. And because you would be new to meaningful use, you're going to want to demonstrate that in the first 9 months, so by October 1st of 2014. There are a ton of other questions here, and I wish that I had a chance to be able to answer all of them for folks, but please visit our website. A lot of the questions that you have are available here. The presentation here will be available online, as will the slides, and I'm going to turn it back over to Karen at PAHCOM to close us out.
Wow. OMG, Robert. You are so knowledgeable on this topic and speak so well to the practice management specifics. We're very, very grateful to be working with your office and CMS to bring this quality education and training to our members. And please, everybody, do visit PAHCOM.com for more information on EHR. I put another link up on the left margin there. You can see we have an EHR specific page up there, and we'll be working to make sure that stays updated. And also the youtube.com/PAHCOM is going to have the video recording of this webinar in its entirety, so you can pick and choose the segments you want to review with your staff and your physician. All right, thank you everybody for being motivated to get things right. We appreciate it. It's a team effort, and it's our pleasure at PAHCOM to make sure that we're looking after the small practice and make sure that we're advised of other information that you need. You can send me an email directly at Karen@PAHCOM.com and let us know what types of information you'd like to see in future webinars. That's what we're here for, and we thank you all very much for your time. Bye-bye now.